Greetings, everyone. Thank you for joining us. We are having several people join right now, so we'll get going in about a minute. All right, we still have several people joining us, but we are at 10 o'clock right now. So Michelle, why don't you take it away?
Great. Good morning and welcome to what's always an exciting day at the Colorado Health Institute. It's the unveiling and launch of the Colorado Health Access Survey 2021. I'm looking over the list of participants. It's great to see so many friends and family among us. And so I welcome to all of you. I'm sorry we can't be here in person, but I guess the good news, if there is any, as a silver lining, is that we all get to be together and reach areas of the state and corners that we typically don't reach with our typical launch. And so I welcome everyone from every corner of the state. Many of you, I can tell from the list of participants, know about CHI, but just as a reminder, we are a nonprofit independent organization that believes that good health policy leads to a healthier Colorado. Every day, we bring research, insight, and expertise to leaders across the state because informed decisions, we really believe, lead to better health for all. As I said, we're independent and a nonprofit organization. We do both public-facing work, which you'll see today, as well as some consulting work that we do with community groups, hospitals, payers, government agencies, and foundations. Before I hand things over to my colleague and primary investigator of the Colorado Health Access Survey, I want to make special mention of the organizations and agencies that make the Colorado Health Access Survey possible. As this survey has grown over the last decade or so, so too have the organizations that have come forth to help us. A big shout out to the Colorado Health Foundation, which is dedicated to achieving health equity. And they are our lead sponsor this year, and we're grateful for their generosity and support. In addition, we thank the Colorado Springs Health Foundation, the Community First Foundation, the Delta Dental of Colorado Foundation, and the Rocky Mountain Health Foundation, all for supporting the CHAZ. And then also a special thanks to several state agencies, including the Colorado Department of Healthcare Policy and Financing, the Colorado Office of Behavioral Health, the Latino Community Foundation of Colorado, and the UCLA Center for Health Policy Research. All have contributed not only to the financial support of the CHAZ, but have helped us think through questions that are important and meaningful to policy discussions as we move forward. So with that, I'm going to turn things over to my colleague, Jeff Bontrager. Many of you know him. He's a longtime friend and to all of us here. Jeff, take it away. Thank you.
Thank you so much, Michelle, and welcome everybody. This is always an exciting day, as Michelle mentioned, at the Colorado Health Institute to release the findings from the latest Colorado Health Access Survey, which we fondly refer to as the CHAZ. I would like to just reiterate Michelle's thanks to the sponsors that really made the Chaz possible. And I also have to give a huge shout out to our collaborators at NORC at the University of Chicago who helped field the survey, as well as the team here internally at the Colorado Health Institute that really made this all possible. So thank you. As Michelle mentioned, my name is Jeff Bontrager. I'm Director of Research and Evaluation at the Colorado Health Institute. I've had the honor and pleasure of serving on the Colorado Health Access Survey team since its inception back in 2008, 2009, and serving as the principal investigator on the 2021 survey. We titled our forthcoming publication that will be posted on CHI's website today, Navigating Uncharted Waters. And certainly over the past year and a half, that has been the situation that the state has found itself in, where we have not only experienced the effects of the COVID-19 pandemic, but a lot of the economic ripple effects of that, and then major movements like the social justice and racial justice movements of 2020, 2021. We have been able to adapt the survey to really provide insights into all of these changing dynamics in our state, and I think you'll find that of great interest today. The way this is going to work today is I'm going to start off with a little bit about the Colorado Health Access Survey, what it is, how we field it, and then I'm going to walk through 10 headlines that we found from the 2021 Chaz. This really is only scratching the surface of the data that are available through the Colorado Health Access Survey. There's going to be a lot of data available to the public free of charge on our website, coloradohealthinstitute.org, and I'll go through some of that at the very end. We want to leave plenty of time for discussion and questions. You can put your questions into either the Q&A or the chat feature. We're going to be monitoring the Q&A a little bit closer, but also looking at the chat. So please put those in there, and I'm going to pause throughout the presentation periodically to respond to some of those questions. So with that, let's talk about the Colorado Health Access Survey. What is it? It is a large-scale survey of Coloradans. We have a completed number of surveys from 10,000 households. Actually, in 2021, the number was closer to 10,500 households. As I mentioned, our partners at NORC at the University of Chicago actually handle the mailings and the data collection, and then CHI does all of the analysis. This survey was fielded between February and June of this year, so the data are really timely. And we are thinking of this as kind of the sweet spot for a survey of this sort. A lot of the questions on the survey have a 12-month look-back period. So we ask people to share their experiences or provide their perspective in the survey based on the 12 months prior to the survey. So as you can see, when it was fielded, it captured really the height of the pandemic, as well as a time when things were really opening up, vaccines were becoming more available, et cetera. So that's going to play into the story that we tell here. The way the survey works is that we draw a random sample of addresses, and we send that random sample of invitation in the mail to complete the survey either online or by calling into a toll-free number to complete the survey. And it is available in both English and Spanish. So the survey is administered in both of those languages, and people have multiple ways to respond to the survey. The vast majority of Coloradans respond online. Some of you who have been following the CHAS for a number of years know that we used to do a telephone survey completely where we actually called people up, called households up. With the advent of caller ID and people just not answering their cell phones and lots of telemarketing calls and things, that part of survey research is really difficult to complete. So we've moved to this, I think, really innovative design of inviting people to participate either online or by calling into this toll-free number. The CHAS has a number of topic areas that have remained on the CHAS since the very first year that we collected. Some of those include access to care, health insurance coverage, the use of care, affordability of care, health status. We ask a number of questions around behavioral health. And then more recently, we have been able to adapt the survey to ask about some of the social factors that we know influence health, such as access to food, access to affordable housing, discrimination in the healthcare system. And I'm going to be digging into some of those topics here today. As you might imagine, there was a great deal of interest in the 2021 CHAS and the questions that we asked. I wanted to thank everybody who participated last year in our stakeholder engagement process. We really took that feedback to heart, and you'll see that reflected in a number of the new questions that we included on the 2021 questionnaire. Some of those include the impact of COVID-19 on households, discrimination in the healthcare system, cultural responsiveness of care. We thank our partners at the Colorado Department of Healthcare Policy and Financing for adding some questions about access to culturally responsive care. Telemedicine, both HCPF and the Office of Behavioral Health sponsored a whole litany of rich telemedicine questions. We're only going to really scratch the surface today, but they mostly deal with experience that people had with telemedicine. Access to childcare, additional behavioral health care experience questions. We have a whole new set of questions about access to oral health services, as well as the suffering that a lot of Coloradans experience from dental pain. So I'll share some findings about that too. We have a new question asking about veteran status, as well as some detailed race and ethnicity questions, transgender identity, and non-binary gender identities as well. So this is only a partial list of the new topics that are on the CHAS. The full questionnaire of the CHAS is currently posted on our 2021 CHAS website, Colorado Health Access Survey website. And feel free to check out the full questionnaire to see what all we asked. Let's dive into the headlines from the CHAS. And the first headline that we have here is that the state's Medicaid program, also known as Health First Colorado, we found lots of evidence on the survey that that program really kept Coloradans covered during the pandemic. Each of these bars represent 100% of the state's population broken down by health insurance coverage or health insurance coverage status. And there are three things that I'd like to point out from this graph. By the way, we've showed just 2 years of data here, 2019 to 2021. The first thing that I wanted to point out is the uninsured rate, represented by these red bars. We did not find a statistically significant increase in the uninsured rate between 2019 and 2021. It went from 6.5% to 6.6%, which meant that statistically it virtually stayed the same. The 6.6% represents about 380,000 Coloradans who lacked coverage in 2021. What we see, though, is when we dig a little bit deeper under the surface, we see some kind of changing dynamics in the coverage of Coloradans. So the second thing I wanted to point out was these big purple bars, which represent employer-sponsored insurance. We saw that employer-sponsored insurance dipped down back just slightly below 50% of the state's population who got their coverage through their employer. That went down from about 52.7% to 50%. And this aligns with our understanding of job loss during the pandemic. Certainly we saw when people lost their jobs, they may have also lost their employer-sponsored insurance. The real story that I wanted to mention, though, is this increase in Medicaid enrollment. Again, Colorado's Medicaid program is known as Health First Colorado. And between 2019 and 2021, we saw a significant increase in the percentage and number of Coloradans who were covered through Health First Colorado. It went from 18.7% in 2019 up to 24.8%, or about 1 in 4 Coloradans who were covered through Health First Colorado. That equates to, according to our survey, about 1.4 million Coloradans. I believe the latest estimates or the latest caseload figures from the Department of Healthcare Policy and Financing are over 1.5 million people currently enrolled. What we think is happening here is the fact that during the federally declared public health emergency because of the COVID-19 pandemic, a lot of people stayed on Medicaid coverage because states were required to keep people enrolled. This is a policy term we call maintenance of effort. So states were required to maintain their effort of keeping people enrolled in Medicaid, regardless of whether people's eligibility changed during that time period. We saw other evidence that Medicaid really kept people enrolled during the pandemic. For example, you'll see this in our forthcoming publication, but the amount of churn in Colorado was at its lowest point since we started measuring it. So churn is a term that we use to describe when people gain insurance or lose insurance or switch insurance during the past year. And that, I think we started measuring churn back in 2011 or 2013, and we saw the lowest level of that since we started measuring it. I think in large part because people were not churning on and off of Medicaid coverage due to this maintenance of effort. We also saw when we asked people who were uninsured why they were uninsured, one of the reasons that we include on the survey is that they lost eligibility for Medicaid or the Child Health Plan Plus. And that went down as well between 2019 and 2021, which suggests further evidence that people who were enrolled stayed enrolled. This is important because there's a lot of energy right now being devoted at our state agencies as well as a number of provider and advocacy organizations to understanding what the potential implications are once the public health emergency comes to an end. The Biden administration just prolonged the public health emergency until January, and then it's a question whether it will be prolonged again or whether people who are enrolled in Medicaid, whose eligibility has changed, what sort of a smooth transition they will have to other coverage and benefits. So that is certainly a big policy issue that we will be continuing to monitor and that I know a lot of people are paying attention to. One of the beauties of the CHAS is that we have a large enough sample size that we can have robust estimates at the local or regional level. This map is showing uninsured rates by the 21 Colorado health statistics regions. These regions are single counties or multiple counties, groups of counties that were identified over a decade ago by the Colorado Department of Public Health and Environment for public health surveillance and monitoring and data collection purposes, and the CHAS has used them for our sample ever since. So you see these rates of uninsurance across the state. One of the takeaways is that, like at the state level, we did not see statistically significant changes in the uninsured rates, either up or down, at any of the regional levels between 2019 and 2021. I would point out a couple of the regions, though. We continued to see some stubbornly high uninsured rates in the I-70 corridor and some of the mountain communities. The resort communities of, Eagle, Pitkin, Summit County, as well as Mesa County, Garfield, and the upper Arkansas Valley had the highest uninsured rate at 13.2% of these regions in the state. We also saw a high uninsured rate in Adams County at, finding it here, 9.7%. Perhaps not surprisingly, some of the lowest uninsured rates, or the lowest uninsured rates, were in some of the more affluent suburbs of Denver. Jefferson County and Douglas County had around a 3% uninsured rate. I would like to say too that when the chart pack, or what we call the storybook, the publication of all the CHAS findings comes out later today, you'll see that we include data on the reasons why people are uninsured. And as I mentioned, there was one reason that we saw went down, which was that fewer uninsured Coloradans cited losing eligibility for Medicaid or CHIP as the reason they were uninsured. We also saw a decline. However, it was still the majority of Coloradans who said that it was because of cost that they were not insured. I believe that it was around 80% who indicated that it was because of cost. And then another one that I just draw your attention to when you review it later is we saw an increase actually in the percentage of people without coverage who said they didn't know how to get health insurance. That was at about 26% of uninsured Coloradans indicated they didn't know how to get it. And I know that there's a lot of people focused on outreach and enrollment that I think will find that finding really interesting and concerning. Let's move on to the second headline here, which really aligns with the first one, and that we found evidence in the Colorado Health Access Survey that the social safety net held during the pandemic. As I mentioned, we have the ability to assess people's access to food and housing. And what we saw, surprisingly, was a decrease in the percentage of people who indicated that they were either food insecure or had housing instability. I'll talk a little bit about what we are measuring here. So on the food insecurity side, the survey asks people whether in the past 12 months there was ever a time when they felt like they had eaten less than they should have because they lacked money for food. In 2019, 9.6% of Coloradans indicated that, and in 2021, about 8.1% of Coloradans indicated not having enough money for food at some point in the past year. So what could be going on here? We speculate that this could be due to a lot of local outreach that happened within Colorado communities as a result of the pandemic. For example, I recall hearing a lot of reports of school districts actually delivering food to families who rely on free and reduced meal programs. I know there was a lot of local outreach among food security programs and food banks to really make sure that people were getting the food that they needed. And also, there were some changes in benefits for the Supplemental Nutrition Assistance Program and other food security programs that may have contributed to this decline that we saw here as well. On the housing side, what we asked on the survey is whether people feel like they are at risk of losing their housing in the next 2 months. So this is really getting at a population that is acutely concerned for losing their housing. In 2019, it was 6.7%. In 2021, it went down to 5.6%. Of course, during a portion of the pandemic, there was an eviction moratorium that was put in place that could have contributed to that decline, but this is something we definitely want to keep exploring and looking into. So even though the pandemic, the headline of this section is that the social safety net held, we also uncovered a lot of evidence of inequities within the data, inequities between different groups of Coloradans when we analyzed the data of the 2021 CHAS. I'll be exploring these inequities in a couple of ways during this presentation. So the first one is around food insecurity. We know that young adults have the highest rates of food insecurity of any of the age groups. So what we did in this particular analysis was we limited this analysis to adults ages 19 to 44. And then we split it out by race and ethnicity. And we were able to display 4 race and ethnicity groups here that had an adequate enough sample size to do that. As you can see, almost a third of Black or African-American young adults indicated that they did not have enough money for food at some point in the past 12 months. Almost 1 in 5 Coloradans who identify as Hispanic or Latino ethnicity did not have food. And this is compared to 9.9% of white Coloradans. And this is really framing my thinking about how we explore these inequities. And one of the questions that comes to my mind is maybe not necessarily what put some of the racial and ethnic minority groups in Colorado at a disadvantage, but what were the factors that shielded the white population from a lot of these really awful impacts of the COVID-19 pandemic, to really examine the underlying forces at work that caused these inequities in the first place. We looked at housing with this interesting analysis of comparing owners versus renters. This was a new question that we added to the Colorado Health Access Survey that asked specifically about whether people struggled to pay their rent or their mortgage as a direct result of the COVID-19 pandemic. And what we found when we compared renters to owners was that among renters, 31% indicated that in the past year they had struggled to pay rent or mortgage because of the pandemic, compared to only 8% of owners. As I mentioned, there was an eviction moratorium that was in place for part of the pandemic. However, that did not allay a lot of concerns that people still had, in particular those who rent their housing, from being able to meet their rent obligations. Throughout the storybook, the publication that will be available today, we have included quotes and vignettes from Coloradans across the state that are really working within communities on a lot of the issues that we address in the Colorado Health Access Survey findings. This is a quote from Christy Galarza, who is a housing manager in Lake County. And I would just draw your attention to the second part of her quote here, where it says, "It is just too difficult to recruit and retain employees when they have no affordable place to live." She speaks to the affordable housing crisis that is hitting a lot of places in Colorado, including our mountain resort towns. And this certainly speaks to me that, or tells me that a lot of our local economy, and specifically, service sector, the service sector that really supports like the resort economies or the ski economy in some of our mountain towns, is dependent on the availability of affordable housing. As I mentioned, our publication is called Navigating Uncharted Waters. So the third story here is around the COVID-19 pandemic. And it perhaps goes without saying that the pandemic changed life for millions. And from a state decision-making and policy perspective, it really was chartering or navigating uncharted waters. So let's talk, though, specifically about how COVID-19 affected households. I won't go through all of these numbers, but I will draw your attention to a couple. These are all new questions, of course, that we included on the 2021 questionnaire. I would draw your attention to the first number in the upper left-hand corner. 38% of Coloradans indicated that they had a decline in mental health, such as anxiety, depression, or loneliness in the 12 months prior to the survey. We found a lot of evidence that, that behavioral health is a huge concern among Coloradans, and I'll go into some of those additional numbers as well. A couple other numbers that I would point out have to do with the financial implications on households. About 17% struggled to pay for basic necessities of living. Another 17%, 16.8% struggled to pay their rent or mortgage. About 12% of people in Colorado indicated that they lost their job because of the pandemic. I would invite you to take a closer look at these numbers that we include in the storybook and on our website later. Let's talk about that behavioral health finding. I'm going to go through this story and then we can open it up for some questions. Mental health troubles really represented a second health crisis after the pandemic. In addition to what I just shared, around 38% of Coloradans 16 and over reporting that they had a decline in their mental health in the past year. We also saw this measure, which was the proportion of Coloradans who had poor mental health. And that's the way we measure that is we ask how many days in the past month did you not have good mental health? And that's defined as anxiety and depression, or feelings of depression and anxiety. And if people indicated 8 or more days in the past month, we defined that as having poor mental health. In 2021, we saw the highest rate of people who reported poor mental health since we've started measuring it. So it was 23.7% of Coloradans who reported poor mental health. We started measuring it in 2013, and the percentage then was 10.6%. Going back to that question on the Chaz about how people's mental health changed during the pandemic, we split this out by age group. And what you can see from this graph is that young adults are really those that were most impacted. So 53.3% of Coloradans ages 16 and over who were 19, I should say, of Coloradans 19 to 29 indicated a decline in their mental health because of the pandemic. Closely behind that are Coloradans ages 30 to 49. About 46 or 47% of them indicated a decline in mental health as well. I know there's a lot of people that are thinking about the demands and the increased demand that this will have on our healthcare and behavioral healthcare providers. This is a quote from Megan Champion, who works at CU Sheridan Health Services, and I think this quote really brings home this kind of double whammy of supply and demand that a lot of behavioral health providers are facing right now, which is that there is an increase in demand. The numbers that I just showed you suggest that the need for behavioral health services is way up in Colorado. And at the same time, a lot of providers are getting burnt out and maybe changing or leaving their jobs, as we're seeing in a lot of sectors within our economy right now. So before I move on, I am going to just pause there, and I have not been monitoring the chat or the Q&A, but Emily or Christy, are there questions that can be addressed right now?
Sure, we've been addressing a couple in the text, but a couple that I'd like to roll up are, we had a question about whether we know anything about the 380,000 uninsured folks with regards to whether they're eligible for Medicaid, CHIP, or subsidies on the individual market.
We have not done that analysis. Thank you, Emily, and thanks for whoever submitted that question. We have not done that analysis based off of the Colorado Health Access Survey. We do have some information available about from another data source called the American Community Survey that has a bit bigger of a sample size, where CHI has estimated the number and percentage of people who are eligible but not enrolled. Unfortunately, the latest year of data that we have for that is 2019, but we'd be happy to follow up and point you to that particular analysis. We certainly can, with the CHAS, look at different characteristics like income that would help kind of get at who might be eligible but not enrolled in Medicaid and CHIP, and also what some of their other characteristics are. So feel free to reach out after this presentation if you're interested in some more analyses along those lines.
Thanks. And just to credit the question, that question was from Catherine Mulready. So thank you, Catherine. Emily Krause also had a question around seasonal workers at the ski resorts, and if that could help explain some of the patterns we are seeing with regards to higher uninsured rates in those areas.
Yeah, that's a great point. So the comment or question is around whether seasonal workers could have contributed to the higher uninsured rates in some of the resort communities. And I think that that's a good observation, because oftentimes seasonal workers are not offered benefits or don't have access to benefits, or they may be more likely to say that they can't afford to purchase private health insurance. One interesting thing that we found, and you'll see in the storybook, is that, and this speaks a little bit to what you're talking about in kind of assuming that a lot of the seasonal workers I'm thinking about in the ski industry are younger, tend to be younger. We did not see the highest rates of uninsurance among what we kind of deemed the young invincibles. This was the second year in a row where the 19 to 29-year-olds had the second highest uninsured rate after those 30 to 44-year-olds actually had the highest uninsured rates in the state. And so we're still kind of putting our thinking caps on around what might be going on there. But it's a very good point about seasonal workers, and that we don't ask about that specifically, but it certainly could be connected to those high uninsured rates. So thanks for that question.
Yeah, and then we've just had another question by Julie around the decrease in supply of mental health professionals, and is this something we saw in Medicaid specifically or across the board? I know it's not a question we asked in the CHAS, but I think, I don't know if there's any additional context from some of the key informants we can provide, or yeah.
I don't know that I have a lot of context right now around the decrease in the supply of behavioral health providers. I would maybe point people towards some of our colleagues at the Colorado Behavioral Healthcare Council or Mental Health Colorado that might be able to speak more about that. And if any of my colleagues at CHI have additional sources of information about the supply of behavioral health providers, feel free to chime in. It's not something we ask about, since this is a household survey, it's not something that we measure with the CHAS specifically, but certainly something that we could look at with other data sets.
Great. I think just the last question from Q&A that I wanted to roll up to you was, Lauren Snyder's intern, wanted to know about underinsurance and whether we examined rates of underinsurance.
Yeah, that's a great question about underinsurance. And the way that we can get at that through the Colorado Health Access Survey is by looking at the people who indicated that they were insured, either publicly or privately insured, and then that they had an issue with affording care that they needed, or maybe that they had foregone some needed care. And I was just looking up what some of those statistics are. So let's see, I am not sure that we have those here in the storybook, but they will be available in some of the workbooks that we're putting. So I don't have them at my fingertips, have those numbers, but if somebody else, Lindsay or Emily, if you wanna look up the percentage of Coloradans who indicated that they had foregone, I should say the percentage of insured Coloradans that said they had foregone needed care. That's going to be probably the best way that the CHAS can get it under insurance.
Yeah, we'll drop that number in the chat shortly.
Great. Yeah, thank you, Emily. Okay. I'm going to keep moving through our headlines, and certainly if you have additional questions, jot those down or put them in the chat or the Q&A. As I mentioned, we looked at inequities in a number of different ways with the CHAS data, and I've already showed some related to food and housing. In these slides, these are two of the questions that we included related directly to the COVID-19 pandemic. And the top one is looking at the percentage of Coloradans 16 and over who indicated that they had reduced hours or income as a result of COVID-19. And the bottom graphic is for those who indicated they struggled to pay for basic necessities as a result of COVID-19. And we broke these out into more detailed race and ethnicity categories. What you can see here is that the yellow bar, which represents Coloradans who identify as American Indian or Alaska Native, had upwards of over half of them who experienced these different struggles during the pandemic. So 52.5% of American Indian, Alaska Native Coloradans indicated reduced hours or income as a result of COVID-19. 41% struggled to pay for basic necessities. You can see a similar pattern with the purple bars, which represent Coloradans who identify as Black or African American. The green bars are those of Hispanic and Latino ethnicity. And then you look at the blue bars, which represent the white population in Colorado. And again, the white population in Colorado had the lowest rates of either of these indicators of the racial and ethnic groups that we were able to identify on the CHAS. One thing that I'm really excited about, by the way, on the 2021 Colorado Health Access Survey is our ability to look at even more granular racial and ethnic identities. So for the first time, we included a category for Middle Eastern and North African, people who identify as Middle Eastern or North African race. The numbers were too small to show on this slide as they were also for Native Hawaiian or other Pacific Islanders. But then within a number of these racial and ethnic groups, we asked additional racial or additional ethnic identity questions so that we can start to uncover and understand some of the nuances in how people identify their ethnicity and differences among people that are often hidden within data sets like the CHAS. We talked to Eric Moore, who is Director of Advocacy at the Center for African American Health. And to the points that I just mentioned, I think Eric's quote here speaks to the kind of place between a rock and a hard place that a lot of people found themselves in during the pandemic. And Eric is speaking specifically to the experience of many people in the African American community, in that, of course, they needed to continue working to address some of those financial concerns, but many people who worked on the front lines or were identified as essential workers had this really hard dilemma of increased exposure to the virus during the pandemic, as well as just trying to keep the lights on in their households. So I just would highlight this last part of the quote that said, our community was particularly affected by COVID, mainly because of lack of access to healthcare and then being exposed in industries as essential workers. Let's talk about the use of healthcare and what we found from the 2021 CHAS. So we asked people whether they have used different types of healthcare over the 12 months prior to the survey. And what you can see here is a decline in many types of healthcare usage, people's self-reported healthcare usage. So we've seen a decline in general doctor care, dental care, specialist care, emergency room usage. The only type of care that we asked about that did not decrease, perhaps not surprisingly, was mental health services. You may be wondering why there wasn't more of a bigger decrease than what we're seeing here in the CHAS. And we suspect that that has to do with the timing of the survey. As I mentioned, it was kind of in the sweet spot at the beginning of this year when a lot of things were opening up and vaccines were becoming more available. So if you're like me, I did not go to the dentist at all during 2020. And then things kind of got to a point where I really needed to go, and I went to the dentist in early 2021. When things were kind of opening up and after I got vaccinated, things like that. So that might be playing out, that sort of a situation might be playing out in some of these numbers as you look here. Telemedicine certainly is part of the story of 2020 and 2021 as our healthcare system really had to do this monumental pivot to telemedicine because of stay-at-home orders or safer-at-home orders. And as I mentioned, we have a rich set of questions on the CHAS. Thank you to some of our state agencies for sponsoring those questions about people's experience in using telemedicine, both about barriers and also about what people liked about telemedicine. And overall, we found that about a third of Coloradans indicated that they had used the telemedicine service over the past year. Of that third, about 80% of Coloradans indicate, 80% of those that used the telemedicine services indicated that they liked it, that it was as good as or better than an in-person visit. And a lot of people cited the convenience of that. And of those who did use telemedicine services, well, actually, this is of everybody. What percentage of people indicated that they would be somewhat, very, or extremely likely to use telemedicine in the future? About 2/3 of people indicated that they would use telemedicine in the future. There were certainly people that indicated that they didn't like it or had challenges using it. And we're diving into those data to look more closely at what some of those challenges were. For the folks who were most likely or somewhat likely to use telemedicine in the future, we examined it by age group here. And you can see that it's pretty evenly distributed, or even we saw pretty even percentages across these age groups. with a little bit of drop off on ages 0 to 18, and then adults 65 and over. And we know that a lot of pediatric procedures need to be done in person. Also know that adults 65 and over may have been less inclined to use telemedicine, according to some other research. So that may be what's accounting for the slight differential that we see there. Harry Buddhasiddhartha from the Asian Pacific Development Center had this quote, and I think it's really interesting because what he points to is that prior to the pandemic, transportation was a huge barrier for a number of his patients to get to their appointments. And telemedicine services have addressed that barrier to a certain extent, made it more accessible for people in the community to get the healthcare services that they need. Story number 8 is around affordability and prescription drugs. We ask a number of questions about whether people felt like they were able to afford their healthcare or prescription drugs. A couple of those questions ask about whether people had unpaid medical bills or had a surprise medical bill. What we found was that 19.6, so about 19% or 20% of Coloradans indicated that they had a surprise medical bill in the past year. And what we've done on this slide is looked at people who indicated they had a surprise bill and those who did not, and then also looked at whether they reported having an unpaid or a problem with an unpaid medical bill. Of those who had a surprise bill, about 33% indicated that they had problems paying a medical bill in the past year, compared to 5.5% of those who did not have a surprise bill. So I know that there's been a lot of policy attention to surprise bills as a way to address affordability issues. I think this will be important for those conversations. The second stat here around affordability that I'm going to present is around prescription drug costs. And again, a lot of policy attention has been addressed towards prescription drug costs over the past number of years. What we ask on the survey, and we've asked this for a long time, is whether people have foregone a needed prescription for medicine due to cost at some point in the past year. What we found in 2021 was that 9.7% of Coloradans indicated not filling a prescription because of cost. This was actually down a little bit from previous years. It was about 11% in 2019. We asked this interesting new question, though, that really tried to tie this affordability issue back to people's health. And what we found is that among those who did not fill a prescription due to cost, 40% of them indicated that it actually made their health condition worse. And speaking of health conditions, we asked a variety of new questions around access to oral health services on the CHAZ, some really great enriched data that are coming about from that that are included in our publication. One that I'm just going to highlight today is around prevalence of dental pain. And why this is important is that we estimate from the CHAZ that 400,000 people or more, the estimated 400,000 people said that they could not participate in regular daily activities like school or work due to dental pain. That represents about 7% of the state's population. And I think also speaks to a degree to access to oral health services. I have to wonder whether people, this is a brand new question, so we can't compare to previous years, but whether this is, has increased because people did not have access to oral health services to an extent during the pandemic. Our final story that I'm going to go over today, and then I'll open it up for more questions, is around discrimination in the healthcare system. We know that systemic racism is a factor that affects people's health. In 2019, we actually asked about unfair treatment in the healthcare system and how much stress that caused people. And a vast majority of people who had experienced unfair treatment indicated that they had experienced stress because of it. This year, we asked more pointed questions around whether people felt like they had been disrespected in a healthcare setting in the past year, or whether they felt like the quality of their care was not as good as what other people receive. So overall, we found that about 4% of Coloradans indicated that they had felt disrespected or discriminated against in a healthcare setting in the past year. Some of the feedback that we got in 2019 was that the unfair treatment questions were not really actionable. Like, what could health systems actually do about it? So we were able to be nimble on the CHAS and to add some new items onto the CHAS about where people felt the source of this disrespect was in the healthcare system. What I think is interesting, so this is of that 4% who indicated that they had experienced that disrespect or lack of quality within the healthcare system compared to other people. Over half indicated that it was due to a clinical staff person of some sort, a doctor, a nurse practitioner, physician assistant, medical assistant, other clinical staff, about 54%. People could report more than one of these options, so that's why these don't add up to 100%. This information will be available again in our storybook, so I invite you to take a look at this, as well as some additional information about why people felt that they were discriminated against, whether it was because of their income or their gender or race or sexual orientation. And you can take a look at those data as well. So with that, thank you very much for your attention. I know that this is a lot of information, but let's open it up for some additional questions. I know we have some time scheduled here for questions and discussions. So Emily or Christy, were there additional questions that have come in?
We had one question that just came in around whether we know why people might not have used telemedicine. Whether is it because of cost, because poor audio visual connection, etc.
Yeah, I will take a look at what our responses were there, because I don't have them off the top of my head.
Oh, and I'm sorry, I didn't mean to put you on the spot there, Jeff.
Yeah, no.
Numbers, but I just wanted to let you guys know that.
Emily, go ahead, go for it.
I don't have the numbers off the top of my head either, but I can put them in the chat. But more wanted to let you all know that these data were out there.
Yes, and we.
So I'll share some in the chat.
Yeah, thank you, Emily. And as I mentioned, we do have some rich information about telemedicine that we captured, and we haven't even scratched the surface on analyzing those data yet around what the reasons were, or the challenges were that people who did use telemedicine services in the past year were. But we did certainly ask a variety of about a variety of challenges, whether it was due to lack of a good internet connection or lack of a device to connect to telemedicine, or if people did receive telemedicine, whether they had difficulty with interpretation or translation, or a stable connection, or just didn't like it, or a lack of a private place from which to join. So we do have a lot of that, and we're going to be diving into that more. Thanks for the question.
Very quickly, I'm going to jump in, Jeff. We're hearing a couple people in the chat who are having a hard time hearing the questions. So if we get other questions, I'm just going to ask you to repeat those questions as you answer them.
Great. Yeah, thank you, Christy. And just that last question was around challenges or why people may not have used telemedicine services in the past. Other questions? Okay, Well, if there aren't other questions,
I'll respond very quickly. Sorry, Jeff. I'll respond to a couple of questions that came up in the chat. And one of them was related to whether or not we have additional data on people who skipped care due to costs. Correct me if I'm wrong, Jeff. We don't break that down in terms of what type of cost. We do, though, take a look at the results of skipping care. Is that correct?
Yeah, we ask skipping care, and just to repeat that for folks who may not have been able to hear, the question essentially was, what else can we tell or can we know about people who skipped care due to cost? And the first thing I'll say is that the Colorado Health Access Survey explores this from a number of dimensions. And so we ask whether people skipped general doctor care due to cost, whether they skipped a prescription due to cost, skipped specialist care due to cost, or skipped dental care due to cost. So we can look across those for individually. We also have a set of questions that the Department of Healthcare Policy and Financing sponsored about whether people skipped care for a reason other than cost. And then once we can subset the population to those who did skip care due to cost. We can look at any other item on the CHAS and how the distribution, how they were distributed by demographic characteristics like age or gender, or their use of healthcare services like dental care, or whether they used emergency room care, whether they had unpaid medical bills. But we can look at other characteristics due to cost. Now, can we tell whether they skipped, was it a primary care visit due to cost or a knee replacement due to cost? We don't have that granular of data on the Colorado Health Access Survey, but we can learn a great deal of people, a great deal about people who reported that issue just based on additional analyses of their demographic characteristics and other responses on the survey.
Jeff, we have a question from Lene Hutton, and if it's okay, Lene had her hand up, and I will just ask her to unmute.
Great, Lene, go for it.
Hi, good morning. This was a really interesting set of information here, so thank you. My question was around the last slide where you talked about the questions around disrespect in the healthcare system. And I'm curious, were there questions that were asked around how people felt treatment decisions were being handled? And the example that I just think of is, research isn't always equitable across all races. And so mammograms, for example, don't always detect lumps in the same way across all races. And so were any questions asked around that area to try to dig into that piece, or was it mostly around how people felt they were being treated in the healthcare system?
Yeah, thank you. That's a great question. And it is more the latter. We ask people how they were treated in the healthcare system and then their perceptions of discrimination in the healthcare system. We don't ask necessarily about treatment decisions, although certainly that could, the way the treatment decisions were made could have played into how people responded on the survey, but we don't specifically ask about those treatment decisions. One thing that I do want to point out, however, is that we have a set of questions that also get at access to culturally responsive care. So this is getting at kind of a different construct than discrimination in the healthcare setting. And these questions were sponsored by the Department of Healthcare Policy and Financing about whether people felt like the care they received or whether they had access to culturally responsive care, and whether there were particular characteristics like whether they had experienced domestic violence, for example, or were a refugee, that factored into the type of care that they need, and then whether they feel like they have access to that type of care. And so we're looking forward to analyzing those. That is not reflected on this slide or in the chart pack yet, but we are looking forward to analyzing those as well. I know that's not exactly answering your question, but I just wanted to take that as an opportunity to say that we do have that sort of information. And thank you again for your question.
No, thank you for the information. Very helpful.
Other questions? I see there's quite a bit going on in the chat, although I'm not even going to try to look through it all right now. Emily, Christy, Joe.
So I know folks are kind of having a hard time hearing me. So if you can repeat this question, Jeff. There was one question we had from Bethany around whether we were able to provide skipping care due to cost information by insurance type to get at the role that copays, et cetera, might play. And so we dropped some stats in the chat around that.
Great, thank you, Emily. Yeah, so the question was around whether we can split out the skipping care due to cost by insurance type so that we could start looking at, the possibility of to what extent maybe copays or other types of cost sharing might impact people's decisions. And so thanks to my colleagues at CHI for dropping some of those statistics into the chat already. Emily, was there anything else you were going to say?
Yeah, and there was one other question around whether we can do any splits to see who did and didn't work from home to maybe see what impact that could have had on a lot of this.
Oh, okay. So the question was, can we do splits by people who worked from home or did not work from home to see what sort of impact that had? That's a really interesting question. Thank you for that suggestion. And I think what we could do is we have that new item on the CHAS about whether people worked from home as a result of the COVID-19 pandemic. And we could certainly look at what their responses or rates of foregone care due to cost were among that population. So if that would be helpful, I don't think we've done that yet, but if that would be helpful, feel free to reach out to us afterwards and we can run those numbers for you.
Great. And then one last question that Jeff, I know is often on your mind. Julie mentioned that it could be troubling to see higher rates of people foregoing care due to cost on Medicaid when they should have no copays. So I know we've talked about this in CHI a bit. Can you maybe provide some thoughts around why we might see that, or just kids, she's emphasizing?
Yeah, okay, so Julie, thank you for the question, and I'll just repeat it here. It is why we might see people reporting foregone care due to cost who are covered in the Medicaid program, which really has minimal or to no copays or cost sharing in as a part of that program. And that is a question that we, as Emily said, scratch our heads a lot about, is why would people who are enrolled in Medicaid report some of these affordability issues? There's a couple of hypotheses that we have around this. First of all, is when you are at the lower end of the income spectrum, I think any cost or even perception of a cost can be amplified for you. And so that could be playing into people saying that they may have just perceived that something was going to cost a lot, and so they didn't even seek care in the first place, or they went without it because of the perceived cost. That may also speak to people not understanding their benefits I have to wonder about people who may have moved to Colorado. We know that we've been seeing a lot of population growth here within the state, and people who may be new to Colorado and new to our programs here, new to how to get enrolled or how to take advantage of some of those benefits. Also, it's possible that they may have sought a service that was not covered by the Medicaid benefit package, although Medicaid does have a fairly comprehensive benefit package. So that could be part of it as well. If there's something like eyeglasses or an elective surgery of some sort or something like that, that people may have gone without because it wasn't covered through their through Medicaid or another public program.
Thank you.
Yeah, thanks for that question. Okay, if there are no other questions, and I see some really robust conversation happening in the chat, so I'm really excited about that. I'm going to just mention that it's very important to the team at the Colorado Health Institute that we make the data available to all of you to support the work that you are doing. And we make it available in a variety of different ways so that you, depending on your level of comfort with data, you can still utilize the CHAS data. So we've listed a couple here. We will be posting soon a number of workbooks that are by topic, and that they're broken down by demographic or other characteristics, and then over multiple years of the Colorado Health Access Survey, so you can look across years. We also have developed profiles for each of the 21 health statistics regions, so you can take a regional glance at how the CHAS data, what the CHAS data found. We have a public use file that we will be posting within the next week or two for those who want to analyze their own data and have, the statistical software to be able to do that. Our storybook is our signature publication that we have and will be posted, I think, shortly after this webinar, so check that out. And when you signed up for this webinar, you should have gotten a question that asked you about your address and if you wanted a hard copy storybook mailed to you. We regret that we can't be in person with you. That's always a fun thing about the CHAS launch sessions that we've had in the past, is that we are able to pass out the hard copy of our storybook that I know a lot of people use as kind of a desk side reference. I've got mine from 2019 here within arm's length at my desk here at CHI. And so if you would like a hard copy and you signed up, we will be mailing those towards the end of this week. If you did not submit your address or would like hard copies or additional hard copies, feel free to just get in touch with us and we would be happy to drop some in the mail for you. Also, the survey questionnaire is available online and we will be posting a full methodology report here within the next week on CHI's website as well. So feel free to continue checking back as we post new items, and we will be also doing a lot of additional analyses, deeper dives into different topics in the CHAS. As always, if you can't find what you're looking for or you have a specific question, you can feel free to get in touch with us. We would be happy to run numbers for you and get those over to you. So we do that free of charge. So feel free to just give us a call or send us an email about that. Let's see, Christy, did I forget anything from a launch perspective here with what we are making available?
I don't think you did. I think you've covered it.
Great, thank you.
And then Jeff, we did have one question that has sort of a nuanced answer around whether data are ever available by city or county. And Yeah.
So the question is whether data are available by city or county. We do have some county data available already, especially for those urban counties where we had a large enough sample size. So some of the health statistics regions are single counties in and of themselves. So if you're in Denver or Jefferson or Mesa, let's see, I think El Paso and Teller are lumped together for health statistics regions. Some of these are single counties or two counties that are lumped together. We do have data that are readily available. If there's a particular county or city that you are interested in, feel free to reach out. We may be able to provide estimates depending on where it is. And it all comes down to how the survey was sampled originally as to whether we would have those estimates available. If we don't have it from the CHAS though, hopefully we can point you to another source that would have the information at that geographic level for you. Okay, anything else? Well, it is never too early to begin thinking about our next survey. So soon after the launch and the release of the 2021 findings, the Colorado Health Institute team is already going to be thinking about the 2023 Colorado Health Access Survey. About a year from now is when we want to have a finalized questionnaire for the 2023 survey. If you are interested in what appears on that survey, if you're interested on sponsoring items or supporting the Colorado Health Access Survey in future years, feel free to get in touch with us. We are having those conversations currently, and we look forward to a robust stakeholder engagement process here in 2022, which is going to be here before we know it, and to learn really what are going to be the most pressing questions that will help you in your work that we can include on a survey like the Colorado Health Access Survey. As I mentioned, the beauty of the CHAS is that we can be quite nimble and responsive or anticipatory of what the topics are going to be that will help inform decisions across the state. My contact information is here, and but feel free to reach out to any number of folks on the CHAS team. I'll turn it over one more time to my team to see if there's any other questions that have come in or anything else that can be addressed before we sign off.
I'm not seeing any additional questions in the chat, but I did want to remind everybody that we are recording this webinar and we'll have it on the website. If not today, then tomorrow. And we'd encourage you to share it with any colleagues who missed it.
Yes, great reminder, Christy. Thank you, everybody, for your attention and for your interest in the Colorado Health Access Survey. We look forward to engaging further with you in this really important source of information and more importantly, these topics so that we can really provide support in your work for informed decision-making. So we look forward to hearing from you, and thank you again for your interest and attendance. Have a great day, everybody.